Welcome to this week's edition of Ask an MS Expert. I'm Jon Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 100 countries around the world with the news that people affected by MS need to know. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. Currently, I'm a member of the International Progressive MS Alliance Scientific Steering Committee. I'm a district activist leader and trustee for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. As we get underway, I'd like to acknowledge and thank today's premier national sponsor, EMD Serono, and our national sponsor, Janssen. Support from MS community partners helps the National MS Society reach its goal of providing up-to-date information and support through programs like Ask an MS Expert. And thank you to all of you who are joining us on GoToWebinar, Facebook Live, YouTube Live, and Twitch. The MS Society's Ask an MS Expert webcast is designed to connect you with MS experts who are ready to answer your questions on the topics that impact people affected by MS every day. So as I chat with our expert today, please feel free to post your questions in the GoToWebinar chat box. We'll try to answer as many of your questions as we can during the Q&A portion of today's program, and the Society's MS navigators are also online throughout today's program, answering your questions and connecting you with resources. In addition to its physical symptoms, MS can produce emotional changes. At first, it may be difficult to adjust to the diagnosis of an unpredictable disease, a disease that has a fluctuating course and carries with it the risk of progressing over time. And in addition to emotional reactions to the disease, demyelination and damage to nerve fibers in the brain can also produce emotional changes. Today, we're talking with Dr. Anthony Feinstein about depression and anxiety in MS and how to effectively manage these symptoms. Dr. Feinstein is a professor of psychiatry at the University of Toronto, and his expertise is in the neuropsychiatry of multiple sclerosis. Dr. Feinstein has researched behavioral disorders in people living with MS for 26 years. He also maintains a busy clinical practice in which over 80% of the patients are living with MS. Dr. Feinstein's studies entail detailed neuropsychological testing, both structural and functional brain imaging, and quantification of mood symptoms. More recently, Dr. Feinstein has begun a series of studies looking at how cannabis might affect cognition and brain imaging in people with MS. Welcome, Dr. Feinstein, and thanks for being with us today.
Thanks, John. Good to be here.
Depression is one of the most common experiences among people with MS. In fact, about half of all the people diagnosed with MS will experience clinical depression at some point in their lives, and that rate is higher than what we see in the general population. It's even higher than what we see in other chronic diseases. So I hope you'll get us started today by defining what depression is and helping us understand what factors contribute to depression.
Right, so depression is a mood disorder, so it involves a change in mood, and the predominant mood is one of sadness. It can also be irritability, which is quite common as well. You can get a combination of sadness and irritability. But when you look at the syndrome that defines a condition that we call major depression, it's not just sadness or irritability, but it comes with other symptoms as well, such as a disturbance in sleep. The individual may sleep less than usual or sleep excessively. You often get a very typical sleep pattern of early morning waking. The individual goes to sleep, falls asleep okay, but then wakes up at around 3 or 4 a.m., cannot go back to sleep, and the day stretches before them with a sense of dread. You just don't want to face the day. It can come with changes in appetite, in which you lose your appetite and lose weight, or you could eat excessively and put on weight. And then there are going to be the negative cognitive beliefs that come with depression, such as feelings of guilt or worthlessness or hopelessness or pessimism about the future. The diagnostic features also contain cognitive difficulties like poor concentration. And then the depressed person may feel that life is not worth living, and there may be suicidal thoughts or suicidal plans. And so you can see you've got this whole syndrome of signs and symptoms that help us diagnose a condition called major depression.
And what factors contribute to major depression?
So in MS, it's going to be a complex causality. On one level, you can say, well, you've got this disease, which is severe, there's no cure, it comes with uncertainty. And so the individual can have a depression as a reaction to what MS deals in. So you have this reactive hypothesis. But then there's also the alternative allied hypothesis that MS is a brain disease, and it disturbs brain structure and brain function. And that too by itself may trigger depression, because we know that depression is a brain disease. And so you can have a combination of factors. You can have the psychosocial, the reaction to a tough disease, reaction to disability, but at the same time, you could have depression being driven by the brain changes that are integral to multiple sclerosis itself. And of course, you can have a combination of factors as well.
So depression could be a reaction to MS, but it sounds like it can also be an actual symptom of MS.
Yeah, and that's a great question, and that's where the debate is. I mean, you mentioned in your introduction how common depression is in people with multiple sclerosis. We know that MS affects the brain in profound ways. We also know that depression comes from a disturbance in brain function and brain anatomy, and so putting the pieces together, it's quite plausible that depression may be generated from MS itself and is such a symptom of multiple sclerosis. Now, it hasn't yet worked its way into the MS diagnostic features. We don't say, well, if a person's got depression, that kind of cements the diagnosis of MS. We're not there yet. But current neuroscience research does indeed show a fairly robust link between brain lesions, brain atrophy, disturbed neural networks, and the presence of depression.
A moment ago, I heard you mention irritability, and Stacy mentioned, she wrote in mentioning that her irritability builds up quickly and her emotions can be unpredictable. Is this something common in MS?
I see this all the time in my clinical practice. As I say, you could have irritability as part of the broader syndrome of major depression, but you can also have irritability as a standalone symptom. And there was some research done a couple of decades back in which they went into an MS clinic on any one day, very busy MS clinic, and they did a survey of various symptoms. And irritability was present in about 40% of people attending the clinic. And so irritability is very, very common in people with multiple sclerosis. The individual knows it. The people that they live with certainly know it, because they can be the brunt of this irritability. So I see this all the time clinically.
People sometimes lump anxiety in right along with depression, but they aren't really quite the same. Persistent anxiety isn't natural or inevitable, even in people with MS, but it can be very common. Dr. Feinstein, how is anxiety different from depression?
Right, so you will remember that I said depression is a disorder of mood. It's predominantly a feeling of sadness or irritability. That's not anxiety. Anxiety is a sense of worry, often an anticipatory worry linked to something, such as my finances, my relationships, my illness, my symptoms. And anxiety can be divided up into various subcategories. There's generalized anxiety. There can be a sense of panic disorder. Qualitatively, it's different. Now, you can get anxiety together with depression. That's not uncommon. We talk about the comorbid effects of anxiety together with depression. And indeed, there's a condition that's defined by the American Psychiatric Association called a major depressive disorder with anxious distress. So there's a recognition that for some people, anxiety can accompany depression. But equally, we see individuals who have anxiety as a standalone symptom or a standalone disorder, and depression is a standalone condition. I should add that when you've got anxiety together with depression in one individual, it can make for a more complicated treatment, and it may lead to a more problematic outcome.
In the past, anxiety wasn't thought to be a symptom of MS. Has that changed?
Well, once again, we have to be careful. We don't know whether it's integral to the disease itself, like depression, although I think it is. I mean, anxiety, like depression, is going to be generated by changes in the brain. And so in theory, MS alone could cause anxiety. But I think one of the reasons why anxiety was overlooked for so long was because mistakenly people would think, well, MS is a tough disease. Of course, you're going to be anxious about it. Just assuming the reactive hypothesis. Yes, the disease will make you anxious because of what MS is. But I think that's a gross oversimplification. I think as neuroscience becomes more sophisticated and our brain imaging techniques improve, we will be able to start teasing out what is the neural basis of anxiety in people with multiple sclerosis.
Ellen has written in about her sister. Ellen's sister cries at inappropriate times, and she really can't seem to control it. Ellen wants to know if this is common and if there's anything she can do. It sounds like Ellen may be describing pseudobulbar effect. Can you tell us what that is?
Yes, that is a fascinating syndrome that you can see in up to 10% of people with multiple sclerosis at varying degrees of severity, but it refers to people who cry when they're not sad, or who may laugh when they're not happy, or you can have a mixture of the two, the crying and the laughter in the same person. And basically it represents a disconnection of one's subjective emotions from the outward display of emotions. So affect refers to what you observe in a person. So if you tell me you feel sad and I look at your face and your face looks sad, your affect is one of sadness. So what you see in pseudobulbar affect is you get this disconnection. The individual cannot control the outward display of emotion, even if subjectively they don't feel happy or sad. As I say, it can affect up to 10% of people with MS. It can be socially very embarrassing. You can have people who laugh inappropriately, even when the situation is not funny, because they can't control the laughter. And sometimes the crying can be excessive. You just cannot stop crying. You can't turn off the crying, even though, this is the clincher, you don't feel sad. That's the typical definition of pseudobulbar affect. And maybe we can get a chance to speak a little later about treatment because it can be well treated.
Indeed, we can. I was going to ask, people sometimes mistake pseudobulbar affect for depression.
Yes.
Can you first tell us how they're different, and then we can get into treatment as well?
So it's easy to understand why the mistake is made, because if you see someone crying profusely, you automatically assume the person is sad. That's the normal human emotion. We're sad and we cry. But the pseudobulbar affect, the person who's crying is not feeling sad inside. There's no subjective sadness. You've just lost control of the outward display of emotion. And that's what distinguishes the two. And in people with pseudobulbar affect, you don't get the other features that are defined as part of depression. So you don't get the typical sleep disturbance, or the negative thoughts of guilt or self-worth, or the suicidal thinking, etc. It's really a very isolated loss of control over your ability to control your crying.
You mentioned a moment ago that pseudobulbar can be treated. Can you talk a little bit about treatment?
Right. So there is one drug on the market approved by the FDA in the United States. It's not available in Canada for the treatment of pseudobulbar affect. And it's a fascinating story. It's a combination of dextromethorphan, which is a cough syrup, as you know, and quinidine. And it was one of these incidental findings in medicine. The medication was not initially designed to help crying and laughter, but they found that individuals who took it had an inability to cry, to show facial affect. And so the drug was pivoted towards the treatment of pseudobulbar affect, which can occur not just in MS, but in many other neurological conditions, dementia, traumatic brain injury, ALS, etc. And so you have this one drug that is now specifically on the market for pseudobulbar affect. That said, there are other medications that can treat it as well. The syndrome responds well to a selective serotonin reuptake inhibitor. For example, a drug like Prozac can be quite effective at turning off the excessive crying or the excessive laughing. The older antidepressant drugs, the tricyclic class, a drug like amitriptyline, Elevil, is also effective at treating it. In fact, there was a paper in the New England Journal of Medicine back in the 1980s about how low dose Elevil, amitriptyline, turned off the pseudobulbar affect. And what's intriguing about the treatment response is that individuals who take the medication respond very quickly, usually within about 48 or 72 hours. When you look at the delay in terms of treating depression, someone who takes an antidepressant drug who's depressed can wait 2 weeks or longer to get the benefits. The pseudobulbar affect, you see a much quicker response, which tells us once again that we're looking at a different brain mechanism causing this.
Shifting our gears back to depression for a moment, severe depression can be a life-threatening condition because it can include suicidal feelings. One study found that the risk of suicide was 7.5 times greater among people with MS than the general population. What are the warning signs of suicide?
Right. I'm really glad you asked this question because as a clinician, there's nothing more painful in medicine than losing a patient to suicide. And as a psychiatrist, this is what we confront regularly. We confront suicidal thinking regularly in our clinical practice. When you look at the suicide literature in MS, the current up-to-date wisdom is that the rates are twice what they are in the general population. So still very high, still too high. We did a study a few years back in a busy MS clinic looking at suicidal intent. What factors make people feel suicidal? Because we know frequently suicidal intent can lead to completed suicide. And we showed, no surprise, that it was linked to depression, the severity of the depression, but also to social isolation, and also to individuals who were using alcohol to self-medicate their distress. And those 4 variables, depression, severity of depression, social isolation, and drinking alcohol to excess, was highly predictive of suicidal intent. Now, not everybody who feels suicidal goes on to commit suicide, thankfully. But the other side of the coin is that people can commit suicide without telling individuals in advance of how they're feeling, which can make it extraordinarily difficult to detect. And I've seen this in my practice. I've seen a patient who saw me at a clinic on Monday, seemed fine, saw the neurologist on Tuesday, the neurologist never noted anything, and then later in the week committed suicide. And so it becomes very, very difficult in some individuals to discern what their thoughts are if they do not talk about what they're feeling. Once again, depression is going to be a warning sign, severity of depression, social isolation, individuals who start becoming socially withdrawn, who start cutting themselves off from, those around them. That's when mental health specialists should, be particularly attentive to the question of suicide.
In the study you just cited a moment ago, where you looked at people in a busy MS clinic, were you able to discern differences in the pattern or the prevalence of suicide among people with relapsing remitting MS versus people with progressive MS?
No, we couldn't find that, and the literature doesn't really speak to that. There's no strong correlation with disease course. But what has emerged is that suicide is more common in men. And in fact, if you look in the general population, suicide is more common in men. So women attempt suicide more frequently than men do. But men succeed more often than women. So you see this sex difference in terms of suicide. There's also some data to suggest that the suicide rate was slightly higher early on in the disease. So around about you get the diagnosis and then having to adjust to a fundamentally different lifestyle. That was one Scandinavian study that showed that. So, there are some clues that, we need to be aware of, but, sometimes they're pretty vague clues, like early in the diagnosis. Well, everybody at some point is going to be early in the diagnosis, so that's often not that particularly helpful. I think you have to watch out for social isolation, severity of depression, people becoming socially withdrawn, some obvious changes in behavior, relatives alerting you to their concerns, so important. And be very, very vigilant in the clinical practice about this question. It's one question that I ask my patient at every visit. Even my patients who report feeling well, I always just say, just checking in with you. Any thoughts of life not worth living? Because clinically, I've had situations in which, as I say, patients superficially appear okay, and then to your shock, you find out that within a week or two, they've committed suicide.
Dante has written in saying that he feels like a burden to the people he's closest to. And so he's been isolating himself from his family and his friends. How can someone like Dante assess if they need to seek help?
Right. Well, that's a great question. I think feeling a burden can well be a symptom of depression. The feeling of guilt, burdening other people. I'm making other people's lives more complicated. I'm hurting other people with my illness. And I've heard this expressed frequently of people saying, I'm just a burden. And that may well be integral to the person's depression. My advice would be that if you feel this, number one, you're mistaken. This can be a cognitive distortion. You perceive yourself as a burden because you're depressed. But to other people, they don't see you that way at all. And so you've got to be careful that you don't fall into this cognitive trap in which your thoughts and your self-judgment is influenced by your depression and your low mood. And so my advice to people with MS who feel this way is to reach out to a mental health specialist, explore the origins of where the symptom is coming from, because if indeed it's a symptom of depression, it can be well treated. This is something that you do not have to feel.
Before we continue our discussion, I just want to take a moment to welcome those of you who have continued to join us. Please let us know what's on your mind. Type your questions into the question or chat box in GoToWebinar. We'll address as many of those questions as we can during the Q&A portion of today's program. And MS navigators are online throughout today's program, answering your questions and connecting you to the very best resources. Our Ask an MS Expert program takes place at this same time every Friday. So please help us make sure that everyone knows about it by sharing news about the webcast with your family, your friends, and on all of your social media channels. In the face of MS, people may tend to focus primarily on their physical health, and so end up neglecting their emotional health, which is an essential component of overall health and wellness. Coping with life challenges with MS or with depression and anxiety can be difficult, especially as we've seen mood disorders stigmatized in society. Dr. Feinstein, what's your best suggestion for destigmatizing mental illness and mood disorders?
Oh, John, that's such a big question. We could speak for weeks on that. I mean, this is the challenge that confronts all mental health specialists. And I really think it's a process of education. I mean, you touched on, you can't separate physical health from emotional health. They go together. It's a false dichotomy when you do that. Just think about when you get the flu, what's your mood like? How are you feeling emotionally? You're feeling pretty rotten when you got the flu. So you can't tease apart the physical from the emotional. They're integral. You see this all the time. And I think we have to educate people about this. We also have to let individuals know that mental health is brain health. Often, that the symptoms of mental illness come from a brain disease. People readily understand that if you can't walk or you can't see or you've lost sensation, that there's something wrong with the nervous system. Well, it's the same thing with your mood. If you're sad, if your cognition goes, if you're super anxious, if you've got your pseudobulbar affect, well, where does it come from? It doesn't come from the ether. It comes from your brain health. And so this is a process of education, explaining to people that really mental illness is no different from physical illness. It all comes from the same matter, which is the brain.
Anxiety and depression are two symptoms that can get in the way of almost every aspect of life. What are some strategies our viewers can use to cope with and manage these symptoms?
Right. So on one level, if you've got a full-blown depressive disorder or an anxiety disorder, you need help. And maybe we'll have a chance to speak about what those therapies are. But when you just look at the broader issue of coping with MS, dealing with the difficult illness, there are well-defined coping strategies. We know what is good and what is bad. So let me start off by defining what is bad. We know that avoidance is a bad coping strategy. If you've got a problem and you avoid it, you're not going to solve the problem. Kicking the can down the road is going to create more problems for you. The problems often escalate and get worse. So there's abundant literature, very large behavioral literature showing that avoidance is a bad coping strategy. The second coping strategy that may not be good for you is emotion-focused coping. In other words, you don't want to make important decisions about your life, about your relationships, about your future, when you're in the thrall to strong emotion. For example, if you've got a depression, the depression will influence the way you think. Depression will cloud your thoughts. It will interfere with your planning, with your problem solving. And so if you're going to be making a decision that is emotion-based, that could be a faulty decision. It can come back to hurt you. Now, the other side of the coin is we know what's good. We know what's a good coping strategy, and that's problem-focused coping. So when you see a difficulty in front of you, if you can divide a scheme to work around it, to solve it, to come up with a sequence of events that could help you overcome the particular problem or minimize it, that is a very effective strategy to deal with a problem. And so problem-based coping gives you the way forward. And it's particularly relevant to people with multiple sclerosis who are confronting problems all the time in their day-to-day lives. How do I navigate around a particular problem? Well, ensure that your decisions are informed by problem-based focusing rather than avoidance or emotion-based coping.
You know, mood changes can affect family caregivers or other family members. We've all heard about a condition called caregiver burnout. Can you share some coping strategies for family caregivers or other members of the family who may be experiencing mood changes?
Yeah, once again, so important, because if the caregiver is going to provide optimal care to the person with multiple sclerosis, then the caregiver has to be in good health. If the caregiver is starting to develop, their own emotional difficulties, it's bad for them, but also the quality of care that they can provide will suffer as well. So it's absolutely essential that caregivers look after themselves. Be aware of your own emotions, your own feelings. Maybe have a check-in from time to time with your family doctor or your own counselor, just to, have a mental health check to see how you're doing. If you've got a very heavy burden of care, then, periods of respite for you are important as well, so that you can have a break, so that you can have some time for yourself. Even when you're providing the care, you need to be able to build into your day moments that are, your time for you to do things, for you to lead your own life, to do the kinds of things that you find fulfilling, other than providing care to a loved one or a friend. And so it's very important that the caregiver pays attention to these items that I've mentioned over here.
We've heard from Janice, who says she was diagnosed with MS just 8 months ago, and she's been struggling with something you mentioned earlier, with that uncertainty of how MS is going to impact her future. And she's looking for advice on how to best cope with this.
Right.
What do we know about the impact of uncertainty on coping with an MS diagnosis, and what advice would you provide to someone like Janice?
I think this is one of the big issues that makes MS such a difficult disease to adjust to. It's the uncertainty. You just don't know what's around the next corner. And, while you can get a rough idea from your neurologist or your neuropsychiatrist what the future holds in store for you, it's almost impossible on an individual basis to predict what's going to happen with this disease. And so this level of uncertainty is a very uncomfortable thing to live with. One of the golden rules about anxiety is this: you can't worry about things that you can't control. If you worry about things you can't control, you just kind of use up your emotional resources. And when you've got a disease like MS, something that you're going to be living with for a long time, you need to conserve your emotional energy. You don't want to expend it on unnecessary worry. And so what I say to my patients in a situation like this is, okay, we're going to make a list. We're going to draw a line down a piece of paper. And on the one side of the line, we're going to put all the things in our life that we can control, and on the other side, all the things that we can't control. And in that column, we know we can't control the uncertainty of MS. We can try to reduce it by taking our disease-modifying drug. We can exercise, and that brings you back to the other side of the line. Those kind of things you can control. I will be compliant with my medication. I'm going to exercise because we know that's good for physical and emotional health. I'm going to pay attention to my relationships because those are supportive and nourishing in terms of how we lead our lives. So you can come up with a whole list of those things that you can control. So you take control back. And by doing so, you minimize the power of uncertainty to upset you. And that's a journey. But when people start getting that and they start realizing, hey, there's a lot of things that I can do to take back control, they feel empowered by that. And it becomes an easier disease to navigate through.
Anna just recovered from a relapse, and she's feeling more anxious than she normally does. She mentioned that she's tried things like taking deep breaths, going to bed earlier, and trying to eat better, but feels as though life is just more overwhelming than it once was. Her friend mentioned that there must be an app for that, something to help track and manage these kinds of things. What advice do you have for Anna, and are there specific apps that you might recommend?
Yes, there are apps. Absolutely. That's why I smile. Sure, the problem is I think there are too many apps. You've got to need an app to guide you through all the apps, to navigate the apps right now. But yes, I mean, there are some good therapies available via the app. And you know what Anna's giving voice to is her anxiety. She's had a relapse. It probably came out of left field. It was unexpected. Quite understandable why this makes you anxious. One of the effective ways of dealing with this kind of anxiety is something called mindfulness-based stress reduction. And I'm a big fan of mindfulness. It teaches you how to relax. It teaches you how to stay in the moment, not to let your thoughts hurry ahead of you, not to catastrophize your thoughts, but to basically stay in the moment and control your thoughts. And there are some good apps for mindfulness-based stress reduction. I'm not here to make a pitch about one or another, but I have found in my clinical practice there's one called Calm, C-A-L-M, which you have to pay a small subscription fee a year, but it's a very good app. You have modules for sleep, for relaxation, etc. And my advice to my patients is that, make some quiet time for yourself every day. Put on your headphones, you've got your mobile phone, the apps on the phone. Go and sit quietly and do one of these modules. Devote 15, 20 minutes a day to some mindfulness. Build it into your day-to-day schedule. Another thing that you can control, another thing in your life that you can take control over, which is how to relax. And this can become a very effective way in helping you with your anxiety.
As you've already made the case, depression and anxiety require treatment, just like any of the physical symptoms of MS. We know that left untreated, depression reduces your quality of life, but it also makes other MS symptoms like fatigue and pain and cognitive changes. It makes them all feel worse, and for some, it can even be life-threatening. What are some of the other effects from prolonged, untreated anxiety and depression that someone might experience?
Well, there's an emerging literature to show that significant depression and or anxiety can worsen your prognosis with multiple sclerosis. So, there can be neurological consequences of untreated depression and anxiety. We know now that depression and perhaps anxiety can lead to cognitive deficits or worsen your cognition. We're not speaking about cognition on this podcast, but there is a high prevalence of cognitive dysfunction in people with MS. And there's now some data to show that depression can slow down your processing speed or perhaps interfere with your executive functioning, and so adds to the cognitive burden. You mentioned it already, that depression is probably one of the biggest predictors of quality of life. I mean, how can you enjoy life when you're feeling sad and miserable? And so depression is a powerful predictor of quality of life. And you raise all these points, they're so essential, and they take on an added magnitude because depression is potentially treatable. You do not have to feel this way. The other point to make about depression and anxiety when left untreated is that it affects other people as well. It affects your relationships. It's not easy to be married to a person who's chronically depressed. And so you see marriages and relationships start breaking down because of the individual's poor mental health. And you lose an important source of support when your partner says, I just can't live with this any longer. So there are multiple reasons why you need to seek treatment for these conditions.
Which really brings us to my next question. What stops people? What are the most common barriers to seeking treatment for something that is treatable?
Well, there are going to be multiple barriers. At one level, the diagnosis is often missed. You know, a person with MS goes along to an MS clinic. It's a very busy clinic. You know, people are passing through quite quickly, and no attention or little attention is paid to mental health challenges. And so the diagnosis is missed. You know, I mentioned a study to you a little earlier in our discussion about, you know, predictors of suicidal intent, the study that we did in Toronto. What we also showed in that study is that individuals who were suicidal had not been detected. You know, it had been missed. You know, we picked it up from a research perspective, but clinically, it had been missed. We showed that individuals who had full-blown major depression had been missed. Their diagnosis had been missed. Or if they had been given treatment, they had been treated inadequately. And so you know, the first barrier is sometimes access to care and the quality of that care in picking up a mental health problem. Other barriers will be, you know, you've touched on it, the stigma of mental illness. People, you know, they feel uncomfortable with this. They don't want to go for treatment. There's, you know, they'll go and see a neurologist, but, you know, they're not so keen to see the psychiatrist. So you touch into the stigma and the fact that certain people feel uncomfortable about this. I do think this is more a generational thing. What I see with my clinical practice is that, you know, my younger patients are often much more comfortable in talking about these issues than someone of my generation. So thankfully, that's starting to change, at least within, you know, our Western cultures. And then there's also a fear. You know, there's a fear of mental illness. People think they're losing their minds. You know, I've lost so much neurologically. What am I going to lose if I see the shrink, kind of thing? You know, am I going to lose my mind as well? And that becomes a barrier for people reaching out for help or accepting help. And so you're going to be these multiple levels of difficulty that need to be overcome before the person actually comes to clinic and gets treatment.
So someone who's seeing their neurologist or MS nurse or MS specialist, someone who is seeing someone other than a therapist, for instance, what's the best way for them to initiate that conversation that can lead to a referral to a professional such as yourself?
Yeah, you know, great question. You have these self-report psychometric scales. You know, so if someone comes to see me, before they actually see me, they might be out in the waiting room. This is before the pandemic, and then they're given an iPad, and on the iPad they've got the hospital anxiety depression scale, which is a psychometric scale recording depression. You know, they click on the answers, and when they come in to talk to me, I can already see what their mood and anxiety scores are, and that can be a little time-consuming for some people. So, you know, there is something called the Yale Depression Questionnaire, which is a single question. Are you depressed? Ask your patients whether they're depressed. What's your mood like? Just ask it. It's such a simple thing to do. And if you get a positive response, in other words, yes, I feel sad, things have changed, I'm not feeling great emotionally, then say to the person, well, perhaps you'd like to speak to one of the psychologists or psychiatrists or mental health specialists attached to our clinic. So, you know, just like you ask a person, do you have a headache, you know, you have a fever, what's your blood pressure like? Ask them, what's your mood like? How are you feeling emotionally? And if you come up with a, you know, a positive response, refer on or have a discussion about why don't we refer you just for an assessment.
Paul wrote in saying that right now he's finding it takes 3 months to get an appointment with a psychologist or to even find a psychologist who specializes in MS. And Paul wants to know, are there things he can do in the meantime, things he can do for himself while he's waiting? What advice do you have for Paul?
You know, I hear this all the time. The wait time to see a mental health specialist. And, you know, it's tough. It's awful for a person with MS to have to go through this. My advice would be, your condition does not necessarily have to be treated by a psychiatrist or a psychologist. Speak to your family doctor. Many family doctors, you know, can screen for depression. Speak to your neurologist. You know, have a word to the occupational therapist or the nurse that's on the MS clinic, someone that you're familiar with. Just raise it as a conduit to maybe getting a quicker referral. I've been part of, you know, consensus group meetings in which we've discussed this. How do you get quicker access to a mental health specialist? The bottom line is, that's a problem that's not going to be solved overnight. But don't wait for the psychiatrist, don't wait for the psychologist. If you're feeling sad, if you're feeling overwhelmed by life, reach out to your family doctor. Say something to your MS clinic. You know, what I'm seeing in my clinical practice now is that patients are doing this. You know, they're speaking to the neurologist, they're speaking to the GP. By the time they come to see me, they've already been started on an antidepressant drug. By the time they see me and I say to them, you know, referral says depressed, and I say to my patient, how are you feeling? And say, oh, much better. Well, why are you feeling better? Because, you know, 2 months back when the referral was made, the doctor started them on some medication to begin with. And so everything doesn't have to flow through the psychiatrist or the psychologist. There are other ways of getting help. If your problem is complex, then yes, you're going to need, you know, more specialized care. But you know, psychiatrists don't have to be the only individuals starting a person on an antidepressant medication. Family doctors can do it, neurologists can do it, nurse practitioners can suggest it. So there are other ways to try and speed up the process.
Well, you mentioned that there are medications available to treat depression and anxiety. Are there methods outside of medications that are also effective at treating anxiety and depression?
Yes, and the answer is yes. I mean, the American Academy of Neurology came out with a consensus paper a few years back. I was part of that, in which we concluded that the most robust data to successfully treat depression is for a psychotherapy called cognitive behavior therapy, CBT. And so there's, you know, reasonable data now to show that CBT can effectively treat depression in people with MS. CBT can be given in person. It can be given over the telephone. So there's good empirical data to show that telephone-based CBT is very effective. It can, of course, be given in a session like this through Zoom or whatever online platform that you use. And now, at my last count, there are 4 computerized CBT programs in which you as the individual can work through a series of modules in which the computer provides the treatment. And there is some preliminary data to show that this is effective too. So to the, you know, the person who wrote in earlier saying there's a long wait time for me to see my mental health specialist and et cetera, my advice would be, well, look into the online CBT programs that are patient friendly and that you may want to try as a means of helping you with your mood. That doesn't mean you don't go through the referral process and see a mental health specialist or your GP or neurologist. Still do that. But there's nothing to stop you from, you know, applying a CBT module to how you're feeling. So we're moving in that direction with computer-generated therapies that may be very effective.
Some of your research has focused on determining brain imaging correlates of depression and pseudobulbar affect in people living with MS.
Right.
What are you learning?
So to put it in a historical context, this was one of the topics of my PhD back in the early 1990s. And to my disappointment, it was a negative study. We couldn't find any imaging correlates of depression in people with MS. And the reason became clear over time. The early MRI machines were not powerful enough. You know, the very first MRI machine was a 0.5 Tesla field strength. The current MRI machines are 3 Tesla, you know, so much more powerful. And as the brain imaging became more powerful, and as the techniques for analyzing the brain became more sophisticated, we could indeed find correlates with depression. So what we now know is that if you've got clinically significant depression, there are certain brain changes in parts of the limbic brain, the emotional brain, that are associated with the mood change. And that can entail a particularly high lesion load in parts of the prefrontal cortex or parts of the temporal lobes, that's part of the limbic brain. We know that selective atrophy or shrinkage of the brain in frontal temporal regions can be associated with depression. My group has also shown that when you look at normal appearing brain tissue, in other words, the brain looks normal to the naked eye, but you extract information from it using a technique called diffusion tensor imaging, we can indeed find these very subtle brain changes once again in frontal and temporal regions linked to the presence of depression. We now know from functional brain imaging, so this is when you look at how the brain activates. So right now, up until now, I've been speaking about structural brain changes, but when you look at functional brain imaging, so the neural networks, how they light up in response to a particular challenge, we now know that in individuals who become depressed, there are alterations in connectivity linking the amygdala to the prefrontal cortex. and the hippocampus to the prefrontal cortex. So we now have defined a network that is associated with mood change or depression in people with multiple sclerosis. We haven't done it yet with anxiety, but we've done it with depression. And when you take all these imaging data, the lesions, the atrophy, the diffusion tensor imaging findings, and you see to what degree this is predictive of depression, we know that the brain MRI now has a predictive variance of about 45 to 50%. So what that says to me is that in some individuals, we can understand the origins of the depression just by looking at their brain MRI. Now, there are going to be psychosocial influences as well. I don't discount those, they are very important. But what contemporary neuroscience is showing us is that MRI, structural and functional, are giving us clues as to why people become depressed. And we see this in MS as well.
That's just amazing work. And speaking of your work, when I introduced you, I mentioned some of the more recent work relates to defining the cognitive and functional neuroimaging changes associated with the use of cannabis among people with MS. First, I'm hoping you can explain the differences between the two major cannabinoids found in cannabis, THC and CBD. Can you help us with that distinction?
It's a very important distinction to make. And the big difference is that one is psychoactive. THC is psychoactive. In other words, it can give rise to psychoactive changes such as euphoria, and in some individuals, even psychosis. CBD is not psychoactive. So it's a more benign substance, as it were, in terms of brain stimulation. It doesn't mean it doesn't affect the brain, it does, but it's not psychoactive. So that's the big difference between the two. And my interest in cannabis was sparked by two things. Number one, the drug was legalized in Canada, as you know, a couple of years back. But number two, I was struck by the number of people with MS who were asking me questions about the drug and the fact that the medical profession knows so little about the drug. So there's a real dearth of good data out there to advise clinicians about the use of cannabis in general and for people with multiple sclerosis in particular. And so it's very hard to give an informed answer to your patient when there isn't data to base or to back up your answer. So I started to do a series of studies, which have been funded now by the Multiple Sclerosis Society of Canada over the past 10 years. And my research is focused largely on cognition, not on mood, because we really haven't seen major mood changes with cannabis use in people with MS. I haven't in my practice. I think the downside of cannabis is this: cannabis THC is potentially harmful with respect to cognition. And to put it in a broader perspective, you really have to smoke cannabis on a regular basis, 4 times a week or more for many years to start seeing the cognitive changes. If you smoke the occasional joint, it's probably neutral in terms of cognition. Maybe not in terms of other behavioral things, but neutral in terms of cognition. But if you're smoking cannabis regularly, as many of my patients with MS are, and you've done it for many years, you can develop difficulties with executive function, memory, and processing speed. And together with these very careful cognitive studies, we brought in brain imaging. And we have a mechanistic understanding now of why this is taking place, because we're able to show that in those individuals who are struggling with their cognition and who use cannabis, we see a different pattern of brain activation compared to those individuals who are not using cannabis. We see a more dysfunctional, diffuse pattern of brain activation. That the kind of neural networks that should activate are activating in a dysfunctional way. And other parts of the brain are intruding on these neural networks, compromising function. Now, if there's any good news to all of this, in a recent publication from my group, we showed that if you stop cannabis, and if you stay off it for 28 days, and 28 days is important because cannabis lingers in your system for quite some time after you stop using it. It's stored in our fat tissues and is slowly diffused out. But by day 28, cannabis is out your system. So we show that by day 28, after stopping cannabis use, your cognition can bounce back. It can go back to where it was before you started to use the drug. And so, my advice to people with MS is be very careful of using cannabis, THC in particular, on a regular basis, long-term regular basis, because potentially it could harm your cognition. The good news is that if you stop, potentially your cognition bounces back. How this plays out with respect to mood is uncertain. We in fact showed that individuals who came off cannabis, their mood improved. That said, I'm aware of a number of patients saying to me, they feel that cannabis helps their mood. And so I'll listen very carefully to that. I think like any drug, you've got to know the benefits and the side effects of use.
You mentioned that your initial scientific curiosity was spurred on by the number of people living with MS, your patients, who were asking you questions about cannabis. So in your opinion, do you see a use for cannabis in MS treatment?
I think potentially, yes. Once again, we make a difference between CBD and THC. When you look at the non-MS literature, there's some evidence to show that cannabis CBD can ameliorate or improve cognitive deficits that come from THC use. So, you may be getting, some benefits from CBD that you certainly will not see with THC. Now, we still have to do the proper clinical trials in people with MS. I can tell you some anecdotal evidence. I have individuals who, in my busy clinical practice, have struggled with depression for many years. They struggled with depression and pain. And we often see this together, pain and depression are tightly linked. And I've had a couple of patients who have found cannabis very helpful in a situation like that, And as a clinician, I listen very carefully to. If a patient comes to me and says, doc, your antidepressants didn't help me. Cognitive behavior therapy didn't help me, but some cannabis did help me. I absolutely accept that. But I think we need to get a better understanding of, where is this help coming from? What is cannabis doing to bring about the benefits? And like any drug, I think we have to be acutely aware of side effects,
Well, you've shared some valuable information with us today about a topic that, as we've discussed, sometimes gets overlooked. And when any sort of medical condition is overlooked, it rarely gets better by itself. In this case, it can actually get worse. So what would you say are the top 3 takeaways that you'd like our audience to remember?
I think that clinics should screen for mental health difficulties. I think it's essential that we detect depression or anxiety when it's present, because we know that in many people, this is treatable. When you miss the diagnosis, you're missing something that's potentially treatable. And when you've got a disease like MS, for which there's no cure, what makes the disease manageable is good symptom management. So when you treat symptoms effectively, it can lead to a profound improvement in a person's quality of life. And that's particularly true for the topics that we've spoken about today. So yes, there are treatments for what we spoke about. That's so important.
Well, I want to thank you for sharing your expertise, and we have time to take a couple of more questions that our audience has for you. Robert wrote in saying he recently changed his MS therapy, and he's noticing changes in his mood. And Robert wants to know if his MS medications themselves can be causing depression or making depression worse.
So that's a great question. I hear it all the time in my clinical practice as well. There were some concerns early in the disease-modifying drug era, back in the early 1990s, when the first drug, interferon beta-1 beta, came on the market. There were concerns that interferon was associated with depression as a side effect. And that led to one of these black labels on the boxes saying, be careful of this drug because of depression is a side effect. Subsequent studies showed that this wasn't the case. Basically, what the subsequent study showed was that depression on a disease-modifying drug was more likely linked to the person being depressed before they started treatment, or perhaps there was a family history of depression that left the individual vulnerable to developing a depression. So I think for the most part, the data suggests that the disease-modifying drugs are relatively safe with depression. That said, there are always going to be individuals who react differently. There are going to be individual exceptions. And so as a clinician, you have to be careful of that. There always are going to be those few patients who will respond differently to a drug. And that different response might entail depression. So I would advise Robert to have a discussion with his neurologist about this. If there's a concern, potentially you treat the depression if you're getting benefits from the disease-modifying drug. If there's a reluctance to stay on the drug, maybe switch to a different drug so you can get benefits of treatment, and perhaps you don't get the mood side effects. So there are different ways of tackling this problem, but it can be solved.
Well, I want to thank all of you who submitted some great questions today, and thank you, Dr. Feinstein, for being with us.
Oh, my pleasure. Thanks, John.
I think that one of the best things that anyone can do for themselves, especially during these uncertain times, is to make sure that the information they're getting is credible and reliable. So we'd like to share some resources with you, and these are resources that you can count on to be current and credible. Taking care of your emotional health is one of the very best things you can do for yourself, and resources are available. Reach out to the Society, the National Alliance on Mental Illness, and if you or someone you know is thinking about suicide, the National Suicide Prevention Lifeline can provide confidential support. Please call or visit any of these resources that you see on your screen. I want to remind you that the National MS Society's MS Navigator team is your best partner when it comes to connecting you to the very best information and resources on living with MS. You can reach an MS Navigator by phone, email, or through the Society's website by chat. And I'll also remind you that the MS Society brings people together through peer connection programs like self-help groups, the MS Friends Helpline and Paired program, and the National MS Society Facebook community. To learn more, please visit the Society's website at nationalmssociety.org/connections programs. Every week on the Real Talk MS podcast, I continue the conversation that we start here. So I hope you'll take a few minutes and give Real Talk MS a listen. You'll find the Real Talk MS podcast at realtalkms.com, Apple Podcasts, Google Podcasts, Spotify, Amazon Music, or wherever you find your favorite podcasts. You can connect with the National MS Society along with others affected by MS on Facebook, Instagram, Twitter, YouTube, and LinkedIn. I encourage you to like those posts, subscribe to the channels, and make sure that you're on the Society's mailing list so you'll continue to receive the latest information on MS and updates on upcoming programs like this one. I'd like to thank Dr. Anthony Feinstein for joining us today. Please remember that a recording of this webinar will be available at the Society's website at nationalmssociety.org/MSexpert, as well as on Facebook and YouTube. And now I have a favor to ask each of you. Getting your feedback on today's webinar is important. So you'll see a survey pop up in a moment when we close out the webinar. And if you're watching on Facebook Live, you'll see a link to that survey pinned to the comments section. And on YouTube, you'll find that link in the program description. Completing the survey makes a real difference. The information you provide helps us to continuously improve, and it helps shape future programs. The survey takes just 1 minute, so I hope you'll take a minute to fill it out. On behalf of Dr. Anthony Feinstein and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices.